session is on managing your pain, and she's going to give you some fabulous things that you can try, or for somebody, a loved one that you might be working with. And of course, there's always science behind everything that she does. Her name is Dr. Linda Bluestein. Did I pronounce you correctly?
Yes, you did.
Okay. And you may see her in Zumba class and other things. She's a great advocate for our Y and has all kinds of exciting things going on with what she's doing. And I hope that she'll tell us about that, because I saw that you brought some pamphlets and cards and things. And without further ado, I shall bring Dr. Linda Bluestein.
Thank you, Becky. So, thank you so much for that introduction, Becky. And I'm not going to spend a whole lot of time telling where my education was or anything like that, because it might put you to sleep. I just want to explain a little bit about why it is that I'm doing what I'm doing. I love teaching, and I love medicine, and so once I got into this part of my career, after treating many, many thousands of patients and seeing that there was a huge difference between different people, and they could have the same list of conditions, but some people were functioning much differently than other people. And over the period of my career, I started to think, well, why is this the case? Why are some people having all these problems, but they function pretty well, and other people have a few things going on, but they're basically completely disabled? And this is really true for chronic pain conditions. There's a vast, vast difference between the amount of disability that one person might have versus what another person might have. And I love teaching. I'm very passionate about education. I'm very excited to be on the faculty of the Medical College of Wisconsin. And so I'm excited to get to talk to you today about some self-help things that people can do. Whether it's for you or for a loved one, there's always some things that can be tried in order to help a person feel better and manage their pain better. And with the opioid crisis that we have going on right now, it's even more critical than ever. People are probably going to find, rightly or wrongly, there's often misinterpretation of these. They're not rules, they're guidelines for me and my fellow colleagues as prescribers. There are guidelines out there in terms of how much opioids we are supposed to prescribe, or what they'll start scrutinizing more how many prescriptions you're writing. So it's very important to be aware of these things and to know various different things that you can do. So, and I also wanted to share just a little bit about the condition that I'm especially passionate about, called Ehlers-Danlos syndromes. And this is a connective tissue disorder, and like some of other multi-system disorders, it can cause severe pain. And this is a group of people that have very much been ignored, dismissed, and have a lot of problems. So this is something that I've gotten very involved with. I wrote a continuing medical education article on this condition, and I also am the physician sponsor. I developed a continuing medical education online program, and there's some information about that in the back. If anybody thinks that they might have this or know that someone that has it and wants to take this to their doctor so that their doctor can learn more, I have some brochures in the back. So I developed this program with a group called EDS Awareness. I'm a medical consultant for them, and I'm also a medical consultant for EDS Wisconsin. Tammy, who's kindly videotaping this and recording it for the people on Facebook Live, who were not able to make it today. So I volunteer as a medical consultant for them as well. So without further ado, and I just wanted to share a little bit about what I'm particularly interested in. So this is what we're going to be talking about today. Whoop. We're going to talk about the difference between acute versus chronic pain, a little bit about why pain is so tricky and what's the problem with opioids. We're going to talk about what are some of the things that determine how much pain you feel, and then what makes a person a successful pain patient, and then we'll leave a little bit of time at the end for question and answers. If you came to see like a PowerPoint presentation, I hope you're not terribly disappointed, because there won't be any slides. Okay? Yeah. Okay. Let me know if you need the Heimlich or something. We don't want to have to do that. Right. And if you came for a diagnosis or have a really, really specific question, just so you know, this is medical information, not advice. I'm not Dr. Oz. I won't magically be able to tell you what's wrong with you and then offer you a miracle cure. So we're going to talk a little bit first about acute pain versus chronic pain. So with acute pain, the pain, sorry, I'm going to block this for just a second here. But the pain is basically usually pretty proportional to the amount of damage in the body. So in an acute pain situation, the pain is there as a protective mechanism. It's there to tell you that there's a problem. You stick your finger into a fire or a flame, your body is then going to take that message and send it up to your brain so that you know to move your hand. So in an acute situation, the pain is protective, and it's usually proportionate to the amount of damage that's inside the body. In a chronic pain situation, we used to think that this was true, that the pain was proportional to the damage, but now we know that in chronic pain, that the pain is actually equal to the sum of the damage and the nervous system processing. So there might be pain and damage in your body, but the amount of pain that you actually feel in your brain has to do with the amount of processing that happens in your nervous system. And our nervous system can either amplify these pain signals or it can dampen these pain signals. A good example is osteoarthritis, which is a pretty straightforward pain situation normally. It's an example of nociceptive pain. But if you take a large population of people and you do MRIs of their knees, you'll find that actually 30 to 40% of people have severe damage in their knees, but they don't have pain. Likewise, you can do an MRI of a knee, and you can find that 10% of people with a completely normal knee MRI have severe pain. So we know that in chronic pain, this is no longer true. So there are a lot of other factors that go into how much pain a person feels. So why is chronic pain so tricky? Well, we can't see it, we can't hear it, we can't touch it, and we can't feel it. The patient can feel it, but for me as the doctor, I can't do any of these things. And as doctors, we like to be able to see things, we like to be able to hear things, and we like to be able to touch things, and then we can provide a measurement for them. So say, for example, you come in and you have a heart murmur. And we're gonna rate that murmur like a 3/6. Well, as we go through the course of treatment, then we will know if the murmur is getting better. It's something that we can actually measure. And things like cholesterol or blood pressure, we can actually measure these things. So then we know our treatment is working. But with chronic pain, the problem is we aren't able to measure these things. And the primary goal usually on the part of the patient is for their pain to be completely gone. Well, only they're the ones that can tell us if the pain is completely gone. And sometimes that goal is not very realistic. Unfortunately. It's understandable that they want the pain to be gone, but that's not always something that's possible. So it can be quite challenging. So instead, a more realistic goal is to improve function. So as a physician, I try to help people to focus on improving function rather than the elimination of pain. And so my role as a physician is to provide people with the necessary tools in order to help them manage their pain better. So that requires that the patient take an active role in their own care. And that's something that's hard for some people, but it also is empowering. They realize that, well, there are things that I can do. Yes, I can take a pill and hope that things get better, but with chronic pain, whether it's opioids or some other drug, the pain doesn't just go away with taking any kind of a pill. Most of our pills aren't going to just completely eliminate the pain. So there are 3 types of pain. I just want to briefly tell you what those 3 types are. They're nociceptive, neuropathic, and centrally mediated. So nociceptive pain, looks like you want me to write that down.
Yeah.
Okay, so nociceptive pain, a good example is like knee osteoarthritis. Okay, nociceptive pain is what most of us think of when we think about pain. It's tissue damage pain. So nociceptive pain is, it could be like an ankle sprain, or a torn rotator cuff, or poor Aaron Rodgers and his fractured clavicle.
Yeah.
That's nociceptive pain. We can see the damage, and we know what's causing the problem. That's nociceptive pain. The second type of pain is called neuropathic. And some examples of neuropathic pain are post-amputation syndrome. After a person has a leg amputated, they often actually have pain in the leg that's no longer there. Well, you can imagine how hard it is to treat that pain when the part of the body isn't even there anymore. But that's an example of neuropathic pain. Neuropathic pain is when the pain is actually in the nervous system. The pain is actually related to damage in the nerves and in the nervous system. Another example of neuropathic pain is something like trigeminal neuralgia or diabetic neuropathy. Those are other examples of neuropathic pain. And then the third type of pain is centrally mediated. I'm just going to put an M rather than write out the word mediated. So that's the third type of pain, is centrally mediated pain. And the classic example of centrally mediated pain is fibromyalgia. And when people have fibromyalgia, what happens is they develop this syndrome that the nervous system actually amplifies the pain signals. And over time, especially if they don't know the self-help things to do, the pain signals get stronger and stronger and stronger. And actually, what can happen is the parts of the brain that talk to each other, that amplify pain signals, actually become stronger, and those connections become more prevalent. And the parts of the brain that normally dampen pain signals actually become weaker. So this is why there's a lot that's actually happening inside of our brains that, so this is called neuroplasticity. I'll write that one down too. So we used to think that once a person became an adult, that their brain didn't change anymore. And now we know that's not at all true. We have something called neuroplasticity. So our brain is constantly changing throughout our entire lives, and that's why every choice that we make, whether it's what we eat, what we drink, what we do physically, what we tell ourselves emotionally, everything that we do has the ability to affect us. So every thought, every action either enhances those connections or makes them weaker. So if someone decides to go exercise and take a Zumba class rather than laying on the sofa, they're now enhancing those connections that they're using in that class, rather than if they're not really doing anything very active, those connections become weaker. So this is especially important when it comes to centrally mediated pain. Neuroplasticity is something that we can use to help us. So that's very important. There are some conditions that actually involve all three types of pain. So people that have Ehlers-Danlos syndromes, as I mentioned earlier, people who have Ehlers-Danlos syndromes often have all three types of pain. And so this can be a very, very big problem. So it's important to know about these three types of pain because the treatment for each one is a little bit different, okay? So, these are some reasons why pain is so tricky. And another reason why pain is so tricky is because of the effect of opioids. So opioids, we all know that there's a problem right now with opioids, especially in this country. We are 5% of the world's population, but we consume 80% of the world's opioids. And, yeah.
Why is it?
Well, I think part of that is our culture. Our culture here in the United States, I think probably even more so than other places, we want it, we want to have it now. And back in the late 1990s is when the pain crisis really started, and that was a result of several different factors. So one was that pain became the fifth vital sign. So in addition to blood pressure, pulse, heart rate, and temperature, now as physicians we were told, and nurses were told, that we had to measure pain as the fifth vital sign. Okay, so that's one factor. Now all of a sudden so much more attention is being paid to a person's pain. Not that that's all bad, but that was one factor. Another factor was, prior to the late 1990s, we were only supposed, as physicians, we were only supposed to prescribe opioids for chronic pain patients or in acute pain settings. In the late 1990s, suddenly we were told, well, there's this new drug. Purdue Pharma had introduced a new drug, which they said is not addictive, and the regulations and guidelines were loosened, and there was a lot of pressure to prescribe opioids. And another reason why this became a problem was also because of patient surveys. And as you can imagine, patients are very unhappy if you don't give them what they want, even if that's the right thing, to not give them opioids. So those are some of the factors that led to, so pain is the fifth vital sign. Suddenly using these surveys for, basically for reimbursement purposes, things like that. The coming up with OxyContin, which Purdue Pharma said was not addictive. And now all of a sudden saying, we have to be much more aggressive in treating people's pain. And that definitely, all of those factors definitely contribute to the opioid crisis. So I'm going to repeat that figure. 5%, the U.S., we are 5% of the world's population, but we consume 80% of the world's opioids. Okay, so what are some of the things that determine how much pain we feel? The first one is genetics. So there are actually people who have a genetic alteration that they feel no pain whatsoever. And what do you think happens to these people? Anybody have a guess what happens to these people?
I have a cousin like that, and he had appendicitis. He had no idea.
Oh,
They die early, exactly. They die early. So there's a story about a young boy, jumped off a roof, got up and told his friends, I'm fine. Went into his house, and he died of massive internal bleeding. Yep. So you can imagine that if you can have genetics where you have no pain, that you can also have a genetic alteration where you feel very little pain, or you can have one where you feel a lot of pain. Okay? So genetics is something that definitely makes a difference. But who here has heard of epigenetics? Anybody? Tammy's heard of epigenetics. Okay, awesome. Epigenetics. So we have our genetics, we have our genetic DNA that we're born with. But epigenetics refers to the environmental things that happen throughout our lives that cause different things within our genetic background to become activated. So this is definitely a newer concept that we're not just born into something and we're just destined for that for life. So that's the first determinant, is genetics. And the second determinant is mood disorders. So whether it's depression, anxiety, something called catastrophization. Who here has heard of catastrophization?
sounds like it'd be a catastrophe.
Right, right. So catastrophization is when a person feels like things are hopeless, and it's a little bit different from anxiety. When a person catastrophizes, exactly, like everything is the end of the world, and if you have any of those problems, then that can definitely make the pain worse. And there's some really good data about what happens in different groups of people. So if you take, if you look to see what percentage of people have depression, in the general population, it's between 2 and 4%. So I'm just going to color in like these 3 people. So this is 100 people. This is a 10 by 10 grid, not drawn very accurately, but so in the general population, between 2 and 5% of people have depression. In the outpatient clinic setting, about 7 to 9% of people have depression. So now I'm going to color these in, okay? So that's about how many people, in an outpatient clinic setting, about how many people have depression, okay? In an inpatient clinic setting, it's about 15 to 20%. So now I'm going to color these in so we get up to about 17, okay? Does anyone have a guess as to what percentage of patients are experiencing depression with pain clinic patients? If you look at a group of pain clinic patients, what percentage of them have depression? Anyone have any guess?
A lot.
Right, a lot. So the studies show that it's between 10 and 100%, okay, depending on what study you look at. But if you put all these studies together, it's going to be at least 50%. So now I'm just going to do this, okay? It's at least 50%, okay? So this is of patients in a pain clinic, what percentage of them have depression? We can look at it the other way too. Of patients that have depression, what percentage have pain? Anyone have a guess? So of patients that have depression, okay, all patients, everybody that has depression, what percentage have chronic pain?
60%.
Pat, that is extremely close. I wish I had a prize for
She
you.
said.
She gets 60%, and I wish I had a prize for her because 65%.
Smart.
Oh, I must have drawn a
Did you
line.
read the article?
I must have drawn. Oh, it's not an article. This is a combination of 13 articles. Yeah. So I reviewed 13 articles, and between them, the average was 65%. So if you take patients in a pain clinic setting, 50% are going to have depression. If you take a group of patients with depression, 65% are going to have chronic pain. So it works both ways. So who thinks depression causes pain?
Well, it's affects it for sure.
Who thinks pain causes depression? Both. Right. So depression, I should mention this the other way, I can't erase. So pain causes depression, which then causes pain, which then, so it's a vicious cycle, right? Now you could replace this D here with an A for anxiety. You can replace it with the letter I for insomnia. You can replace it with the letter C for catastrophization. You can replace it with the letter I again for inflammation, okay? There's a lot of cycles that happen here. And then another letter we can replace here is S. Anybody have a guess what the letter S is for?
Stress.
Yes, actually stress, but then there's a second S. Anyone have a guess? Social isolation. People get pain, they isolate themselves socially, and then that makes the pain worse. So we have lots of different cycles that happen with pain. And stress can be eustress or distress. Anyone know the difference between eustress and distress?
Is one healthy stress and one is
Right.
not
So
healthy?
So eustress is something that is like emotionally neutral, and distress is something that is very negative. So things are stressful, whether it's that you're getting married or even if you're going on vacation. I mean, that's kind of stressful. You got to pack, you got to work out. Well, nowadays, especially flying, right?
Yeah.
But especially things that cause distress can make pain worse. Okay, and sleep and pain have a bidirectional effect. So pain can make sleep worse, and sleep can make pain worse. So this is a very important factor to address. Okay. The next one is autonomic nervous system tone. Who here has heard of the autonomic nervous system? Okay. So there's two parts. So there's two parts to our autonomic nervous system. There's our sympathetic nervous system and our parasympathetic nervous system. So our sympathetic nervous system is our fight or flight response. So you almost get in a car accident and you feel your heart race and you just feel like your heart pounding in your chest. That's your sympathetic nervous system. And the opposite is your parasympathetic nervous system. That's the one that calms everything back down. Well, I think also in answer to your question about why is this the case in the United States, I mean, every country I think probably has some bit of kind of a go, like we're addicted to our technology and that kind of thing. But I think it's probably worse here than it is other places, I would imagine. And so the more that you are amplifying your sympathetic nervous system and that you're not using your parasympathetic nervous system, the more problems that you can have with pain. It's very important to learn to activate your parasympathetic nervous system, and we're going to talk about that a little bit in a minute. And exercise is also very important. Well, I could replace that with the letter E. You have pain, so then you don't move. Then you get more pain, because then when you move, then it hurts. And so that turns into a vicious cycle. And it's really, really hard to figure out how to get yourself back out of this pattern once you've gotten into it. And then there's another thing called, has anyone ever heard of this? NEAT? Non-exercise activity thermogenesis. So this was discovered at the Mayo Clinic, which is where I trained, and what they discovered was that when people were just more active throughout the day, that they did better than if they were inactive all day long and then went to the gym for 30 minutes. So it's very important just to be moving throughout the day. One of the other determinants is meaning. What kind of meaning do we associate with this pain? So unfortunately, once we've had one chronic pain problem, we're at higher risk of having another one. Well, this is probably why. Because it has so much more significance to us. If we haven't ever had that problem, we're probably not going to assign it that kind of meaning. And that can also make it worse, because now we think, oh my God, here it comes again, right? So all of these things can, and then inflammation, which we'll talk a little bit more about in just a minute. Okay, so, okay, so what makes someone a successful pain patient? So I wish I could tell you that I knew the magic secret that nobody else knows that's going to make everyone's pain go away, or anybody who has a family member with pain. I wish I could tell you that. But really, it's more that I can provide some tools that over time can help a person feel better and manage their pain more effectively. And the first thing that we find is much more common amongst people that are successfully managing with their pain and are functioning more at a higher level is that they're open-minded. And they're willing to explore some of the other things that might be going on that could be contributing to their pain problem. So people that are open-minded and have more realistic expectations, this helps considerably with being more successful in living life despite having pain. And in terms of expectations, there's been some very good studies that have been done, even in acute pain. And I like to quote this one. If you've heard it before, I apologize. But to me, this was a great study because it was done in an acute setting. It was done with actually healthy volunteers, and it was done with an IV medication. So this is not a long-term thing. This is a short-term thing. So what they did was they took a group of volunteers. They started an IV. And they did what's called pressure threshold testing. So that means that they were going to press on their skin, and then they were going to see when they said ouch, and how hard could they push before they said ouch, okay? And so what they did was they said, so we're going to do three different conditions. Under one condition, we're going to give you a very, very powerful pain medication, and it's going to make it so that you can tolerate a lot more pressure. Under the other condition, we're going to give you something that's going to make you more sensitive to pain. And then under the third condition, it's going to be a placebo. It's not going to do anything. Can you guess what happened? So remember, these are healthy volunteers, okay? But they're being told these things. Oh, and I forgot to mention the other part is they're scanning their brains, okay? So to me, this is a really fascinating study, and it's using a drug called remifentanil, which is an ultra-fast-acting, very, very powerful anesthetic drug. And so what they found was that when they gave people when they told them, we're giving you this super powerful pain medicine, and they went ahead and gave them the powerful pain medicine, they were able to tolerate a lot more pressure with this pressure threshold testing. When they gave them the pain medicine, I might have described that a little bit inaccurately a minute ago, in all three conditions, they gave them the pain medicine. So I apologize, but I don't think in all three conditions, they got the IV pain medicine. Sorry, I didn't explain that accurately. In all three conditions, they got the pain medicine, but they looked to see what happened in their brain and what happened with the pressure threshold testing, okay? When they told them, we're giving you a very, very powerful pain medicine, they found that they could tolerate more pressure, okay? And in their brains, the part that dampens the pain signals, those parts lit up, okay? In the condition where they said in the condition where they went ahead and gave them the powerful pain medicine, but they didn't tell them anything, they basically were pretty much at their baseline, okay? Because they did a baseline first to see how much pressure they could tolerate. Pretty much nothing changed. When they gave them the pain medicine, so remember, they're giving them powerful IV pain medicine, but they said, this is going to make your pain worse. The parts of the brain that made pain worse lit up, and they couldn't tolerate as much pressure. Now we have to remember, these are healthy volunteers, right? And this is an acute situation. This is not people who have been living with pain days and days, months and months. So you can imagine what's happening in our brain when we're in pain for a long time, okay? And things are changing and altering. Another thing that people do that are successful at managing their pain is they get educated. They get educated about the science of pain, okay, like you guys are doing today. It's important not to get your education from the University of Google. A lot of people do nowadays, and it's very important to get information that is accurate and scientifically based. The other thing that people do when they successfully manage their pain is they focus on the triad, okay? And what the triad is I like to think of a triad of, you have the medical part, okay, so that's the individualized part that your doctor is managing. And then you have the physical part, that whether it's physical therapy, occupational therapy, but it's movement related, taking an exercise class, going for a walk, that's movement related. And then the third part is the psychology. They're addressing psychological factors. And then these people also are focusing on function. And they're also pacing themselves better. So it's really, really hard. If you have a chronic pain problem, and anyone who either has one or knows someone who has one knows exactly what I'm talking about. You have a good day, and you think of all of these things that you want to do, but you haven't done. So then you go out and do them all, and now what happens? You feel bad. So then you have a series of bad days, and you're not able to do anything. So it's very important to pace yourself and to kind of start to figure out, well, how much can I do without causing a flare? And this is what I mean too about focusing on function and having some realistic goals. It helps to start paying attention to, well, how much can I do before I get a flare? Okay, well, I can do this much. This is my baseline. Now I'm going to start doing some various different things, and I can see can I move that needle just a little bit? Can I make it so that I can do just a little bit more? We also find that people who are successfully managing their pain, they are addressing their moods, whether it be medication, supplements, their diet. They're addressing the anxiety, depression, catastrophization, and well, insomnia shouldn't really be considered a mood, but they're addressing insomnia, okay? That's very, very important. And the people who are managing their pain successfully also are engaging in retraining their brains and also in reframing. And these are a couple of techniques that people use in cognitive behavioral therapy. How many people have heard of cognitive behavioral therapy? Most everybody's heard of cognitive behavioral therapy nowadays. There are many, many, many studies that show that cognitive behavioral therapy does help with chronic pain. Is it a miracle cure? No, but it does help. And with chronic pain, again, it's important to focus on improved function and to think about it as a condition that needs to be managed rather than something that needs to be cured. It's completely reasonable and understandable that people want the pain to go away. I completely get that. But it's important to think about it in terms of functioning better, because that's more realistic. And using humor also really, really helps. That helps release endorphins. Again, we talked about exercise and non-exercise activity thermogenesis. And another important thing is fun. What happens is once people get a pain problem, they stop doing anything that is fun. And it's really, really hard, because it's hard when you have a pain problem. It's hard to think of anything that you can do that's fun. It can be really, really challenging. But even if you can find one little thing and try to add that into your life, it does help. Also nutrition. It's very important to eat well and to eat for lower inflammation. So we now know that neuroinflammation, inflammation within the nervous system, is a big factor both in aging of the brain and in chronic pain. So it's important to think about what foods you're eating, what foods are making inflammation worse, what foods are making inflammation better. And sometimes you need to consider special diets. So there's like a glutamate-free diet. Sometimes you might not have celiac, but you can benefit from a gluten-free diet. There's a number of different types of diets that people have tried. There's something called the Wahls diet, spelled W-A-H-L-S. There's a number of different diets that people have tried. Sometimes people find that some of these things help. And also it's important to try to dissociate your emotions from your pain. So when you feel the pain, to try to stay in a more relaxed state, try to be more like an observer, try to be like a reporter and think, okay, well, this is what's going on. Well, what did I do yesterday that maybe is related to this? And stay in that more calm state rather than the more sympathetic nervous system state that's going to amplify those pain signals. And as a family member, it is very helpful if you can stay neutral, emotionally neutral. Be supportive, but We do. It's hard, especially if it's your child. It's really, really hard, especially if it's a young child. There are lots of young children actually that have chronic pain problems, and it's really, really hard to do this. But there are lots of good studies that show that if the family is not negative towards the person, but also not encouraging these types of complaints, but supportive and helpful, that does help the person cope better with the pain as well. And last but not least, it is very important to feel empowered, and that there are things that you can do to help. And to people that are successful usually they take ownership. This is not my doctor's problem, this is my problem. I'm going to do what I can to make myself better. And they recognize that they are not their illness. So we talked a little bit about acute versus chronic pain, how those two things are different, why pain is tricky, and why opioids are tricky. What are some of the things that determine how much pain a person has, and what are some things that can make a person a successful pain patient? I apologize if I talk too fast. I already went over a little bit because we were supposed to start Q&A at 12:30. So, questions? Yes?
Yesterday in the paper it had that opiates being prescribed was like 60% down, but a lot more people are dying. Why do you think that is?
That's a very good question. So, I think that, so if we look at it as a pendulum, okay, I think what happened was we weren't prescribing opioids at all for chronic pain.
Yeah.
Then we went over here and we way overprescribed. We might now be underprescribing. I don't know, but I think it is possible that we are underprescribing. Even if we're prescribing less, there are people who maybe they don't have pain, but they're addicted. So they're no longer getting their medications from their doctor. So now they're going to the street and they're getting things on the street, which are becoming more and more dangerous because there are, I mean, I'm sure you've all heard of, things being laced with all kinds of things. I mean, people are dying. I mean, you're absolutely right. The deaths are terrible. So addiction is a whole nother topic that we could spend hours on. And because there are people who are taking opioids who have pain, and there are people who are taking opioids that have addiction. So there are two different things. And there's people who are taking opioids because they have pain, but they're now addicted.
Yeah.
So it's very complicated, and it's unfortunately most physicians are extremely busy, and it's very hard to sort out. Okay, this person wants a renewal of their prescription of opioids. How do I handle this? Your average doctor visit is so short.
Yeah.
How do they sort all this out? How do they figure out what to do? And taper people appropriately if a taper is appropriate for that person.
So most people that are opioids get that way initially from the doctor.
I don't know any specific data on that, but I believe that I did hear a statistic something like, and don't quote me on this, but I'm pretty sure that there's something like 60% of opioid-related deaths are related to prescription opioids. But it could be that it was a diversion situation. So maybe it's the family member's prescription and then somebody else took it and now they died. But I believe that I heard that statistic recently that 60% of opioid-related deaths are related to prescription opioids as opposed to street drugs. Yes?
Don't you think pharmaceutical companies pushed a lot onto the doctors? And then also as far as pain, it was, you don't have to take the pain, take some drugs.
Yeah.
And don't you think it's more of a vicious circle than to turn around and say this is the patient asking for pain medication? Because I know like several years ago when my daughter was sick, she didn't have any pain and the doctor says, do you have any pain? No, well here I'll wait for some pain.
Right.
Well, when she didn't have pain,
Right.
I didn't give it to her and she didn't take it.
Right.
Who gave that?
Right.
So I mean, I'm talking a circle, not just trying to blame the patient itself.
Right. Right. Oh, you're absolutely right. The pharmaceutical industry or pharmaceutical companies, especially Purdue, is definitely hugely responsible for so many people that have died because of the fact of saying, no, go ahead, it's okay to prescribe opioids to people with non-cancer chronic pain. So I should have said that up from the very beginning, that what we're talking about here is non-cancer chronic pain. Cancer pain is very different. So I apologize, thank you for asking that question because that made me think of that. We're talking about non-cancer pain. That's a whole different animal. Yes?
So two things, do you work in a pain clinic, and if a person would go to a pain clinic, what should you expect?
That is also a great question. So, yes, I can officially announce as of today, I actually am the president and owner of Wisconsin Integrated Pain Specialists, and my clinic will be opening soon. And I do have some cards in the back for anyone who's interested. And it's also a great question about what to expect when you go to a pain clinic. They are very different. Back in the late 1990s, there were places called pill mills, and that was especially common in Florida. And what people would do is, and these people, I mean, I really think they should be prosecuted for murder and not even just manslaughter, because what they would do, these are doctors who would, they would have thousands of patients come in and out of their clinic. They would not examine them, and they would give them, they would physically give them the pain medicine, and they would make a fortune off of the actual pills, you know, because they would buy them like super cheap, and then they would give them to the patient, and they were making a fortune. And a number of these people had been prosecuted, but that was a huge part of the problem. Was these pill mills? A lot of them were in Florida, but they were all over the country. So finally, those got shut down. But so if you go to a pain, so that's a great question, because if you go to a pain clinic and the doctor doesn't examine you, get up and walk out. Okay. If they don't examine you, then you know that they're not, you know, if it's an initial visit and they're not fully assessing you, then there's a problem, okay? They should examine you, they should be asking you lots of questions, and then the other thing is you want to see what kind of approach do they take. I hate to say it, but there's a lot of people who, they just want to do procedures, so they don't address any of these other things, they just want to stick a needle in you. Now, it's different if it's for diagnostic purposes, because sometimes those procedures can be helpful for diagnostic purposes, meaning figuring out what the problem is. But procedures are way overutilized, and that adds to the cost of healthcare in this country. So if they're immediately recommending that you have this procedure or that procedure, or let's put in this, you know, stimulator or whatever, I mean, there is sometimes a place for those, but that's, you know, like down the road after you've really tried everything. Hopefully they're going to take a much more inclusive approach.
What is that? Is there more chronic pain now than was, let's say, 30 years ago or 40 years ago? Is it decreasing?
I don't have a figure on that, but I definitely think that it's increased.
So it's increased because?
I definitely think it's increased. We're living longer, and we have figured out how to make the heart and lungs, and we look at all the things we can treat. We can treat cancer, we can treat infections, but our joints are still, we still have gravity, you know, and we have wear and tear on our joints, and so we haven't cured that, you know. So I have no doubt that chronic pain has increased. Tammy, you have a question?
There's an online person who is asking, her name's Tracy, she says, is there a specific name for a delayed pain response? Is this common? She has this with EDS.
Delayed pain response? Well, if you're thinking, I mean, I guess it's very, very common to, especially with people that have EDS, that's Ehlers-Danlos syndromes. Again, those are connective tissue disorders, where the collagen is weak, the connective tissue is weak. It's very, very common to, I like to use the analogy of a sunburn. You know, you're sitting on the beach and everything's great and you feel fine and you're enjoying the sun, and you go in and it's not until hours later that you realize that you overdid it and now you're sunburned. The exact same thing happens with exercise and activity, and especially if your connective tissue is weak. You can go and do different activities and exercise, and this happens to a lot of people, and they think that they're fine, and then they have this, we call that a flare, then they have this flare of pain. So that's very, very common. Other questions?
Since the movement is moving away from opioids for treating pain, what is it moving to from a medical standpoint, from a prescription?
Right. So that's why this kind of started out small and grew very, very big for me, because once I realized the incredible difference between what scientists and what healthcare providers knew versus what patients knew. So that's why I ended up getting so passionate about this, because your average doctor doesn't have enough time in an appointment with a patient. They don't have enough time to really go into all of this. You know, I mean, this is like the tip of the iceberg right here. And so our current healthcare model of you know, reinsurance reimbursement and everything is really not adequate to really address all of these things. So, I mean, you raise a very valid point. A lot of physicians are prescribing opioids a lot less or not at all. They're saying, I'm not going to give you any more. And they're not aware of there are other things that can be done. And I specifically didn't go into the medications, well, supplements we could talk about. I'm happy to talk about supplements. There are other medications that can be used, but there's a couple, I didn't really go into that because nobody here will be able to prescribe themselves these medications. But I will mention one, just in case you go to the doctor, is that, hey, there's something called low-dose naltrexone that actually is anti-inflammatory on the nervous system. And the problem is that there are thousands and thousands of articles published in the literature, like every month. So it's virtually impossible. If you're practicing full-time, it's virtually impossible to stay on top of the literature. So a person could have every good intention, they're working in their pain clinic, they're trying to take really good care of their patients, but they don't have time to sit there and read all these articles all day because they're working all day long. That's another problem. So, and there are supplements that you can take. Something like turmeric is very anti-inflammatory. That's something that a lot of people find useful. For people that have Ehlers-Danlos syndromes, vitamin C can be helpful. That's a precursor to building collagen. And it can also be helpful to take glucosamine and chondroitin. That can help to strengthen our connective tissue. So there are some things that we can do in terms of supplements. Yes?
What was the last one you mentioned? Glucose?
Glucosamine and chondroitin.
Oh, glucosamine.
And if you look at the studies that are using glucosamine and chondroitin, the human studies, they use lower doses than the animal studies. So a lot of physicians that I work with are recommending higher than the prescribed dose that you'd see on the bottle. Just like if you go to the pharmacy and you pick up a prescription for Zyrtec, it will say take 1 per day. But if you go to your doctor, they may recommend a different dose than that because, you know, we can. So a lot of people there is data showing that higher doses can be effective for that. Pat?
I was just going to ask if, and I've never had acupuncture, but I just wondered where it might fit into one of the ways.
Thank you for asking that question. Acupuncture, I am a big fan of acupuncture. Again, it's not, and you reminded me of another thing, it's not like you're going to go in and necessarily go in for one session and boom, you're cured, but acupuncture I think definitely has a role, especially when you think about the 10% rule. So the 10% rule also goes back to expectations. So I like to use the lidocaine patch as an example for this. So if anyone here know what the lidocaine patch is? Okay, so lots of people have either used it, heard of it, whatever. A lidocaine patch is probably not going to take away all of your pain. But if you use a lidocaine patch and that takes away 10% of your pain, and you go and you do some acupuncture and that takes away another 10% of your pain, and you take some turmeric and that takes away another 5%.
Now we're feeling good.
I mean,
You're not feeling good, you're feeling better.
Exactly. So this is how we, you know, and I also think that it's important to journal because sometimes I think by documenting these things, then you can actually notice the incremental changes. It's very easy to miss the incremental changes if we don't write these things down. So sometimes it's a good idea. Make a note. Oh, and I should have pointed out, I have some cards back there and also flyers for that Ehlers-Danlos CME program if anyone's interested. So it's important to just, without being obsessive about it, because if you're obsessive about it, then that becomes a problem.
Then it's there.
Correct.
And if you don't document, you're feeling better today.
But,
So,
right, I agree with you. But I think that,
it's kind of a,
right, it's a fine line. But I think if you view it as, I'm going to write this down so that I can put it out of my mind. So I'm going to write it down, you date it, and you write down, you know, I was able to walk 15 minutes today on the treadmill at 1 mile an hour. And then, and then like a week later you look at it again and you see, oh, well, now I'm doing this, now, you know, and then wait a while and look back and see, oh, okay, I guess that is some improvement. But you're right, it's a very fine line. And that's the other thing with all of these things, it's not, So education is another example of don't become obsessive. Don't spend all day looking at things on the internet. And it's hard. It's really hard because who has lost time on the internet? Like you go online and all of a sudden 3 hours have gone by and you had no idea, you know. So it's very easy to overdo on the education. Like kind of get what you need and then move on and try to live your life and try to focus on the good. Try to focus on fun and things that, you know, like for me, and for those of you who know me, know that I have personal experience with this, but this was a huge thing, and Pat knows me from Zumba. This was a huge thing for me when I was able to get dance back in my life. Now when I go to Zumba, I have to modify everything. I can't do things the way everybody else does it, but everybody should do what's right for their body, you know. And for me, being able to put that back in my life was huge and made my brain feel better, and that, you know, again, the incremental steps. But if you overdo it, now you're, you know, so it's all, yeah. Yes?
What about the use of like Tylenol, Advil, things like that? Kind of managing the use of that in regards to, you know, liver damage or whatever that potentially causes.
Right. So my personal feeling about anti-inflammatory drugs like ibuprofen and you know, Advil, and then there's the prescription ones like meloxicam, diclofenac. My personal feeling about those, and again, this is just my feeling, is that if you take them every single day, then once you stop taking it, you have a lot of pain, and they're better if they're used more intermittently. Now, if you're in the middle of a big flare, then maybe it's okay to take it like 5 days in a row, 7 days in a row, something like that. But that can be hard on your kidneys, and also put you at risk for GI bleeding and gastritis and things like that. So in terms of the anti-inflammatories, I prefer to eat a lower inflammation diet than to take that pill. So eliminating things like sugar or reducing sugar. Oh, and I forgot to mention there's a survey flow. Which would be very helpful if people would fill that out, that would be great. So for me, I prefer to accomplish less inflammation through diet rather than through pills. And to answer your question about Tylenol, I also think that you can overdo Tylenol, and it's tricky because you want to make sure that you're using those things appropriately, and they definitely can be beneficial. But there's also something called medication overuse headache. Who here has heard of medication overuse headache? Okay, so again, it's like you have to be careful, because if you end up taking these things on a regular basis, you can actually get a headache from the drugs. So my feeling is that these things should be used. Again, every medication, if you take too much of it, is poisonous to our bodies. So these are all nothing is for free, but our diet is huge. Through our diet, everything that we eat has the ability to increase or decrease inflammation in our bodies. And I probably shouldn't say this in the state of Wisconsin, but dairy is pro-inflammatory. So eating something like dairy, it's a good source of protein, but it can increase inflammation in your body. Things like, again, we're going to get some people mad at me because of being in Wisconsin. Things like meat can increase inflammation in your body. You're better off eating fruits and vegetables and fish and beans and legumes. Things like that are more likely to decrease inflammation. And probiotics.
Just a quick follow-up question on
Sure.
the lower inflammation diet. Is there a particular one that you recommend, or is it just those things you just listed off?
So those things that I listed off are really good. There is a book listed on the resources sheet by Drs. Rao, and it's called Finding Balance. And they talk a lot about inflammation in their book. In fact, the first three I think I asterisked, because I really like those a lot. They're very, very helpful. But that one, Finding Balance, is also very useful, and they talk a lot about diet and which foods are pro-inflammatory, which foods are anti-inflammatory. Sure. Other questions? Yes.
What's your view on the magnetic therapy?
I haven't ever seen any good data showing that it helps. It's probably one of those things that falls into the category of It's not gonna hurt, other than the fact that it costs money, might help. I don't have enough information to recommend it necessarily. So,
Did you say sugar is high?
sugar is very pro-inflammatory. Yeah, of course, sugar, dairy, but the good news is chocolate is anti-inflammatory. Now, dark chocolate, before you add in the sugar. Yeah.
Dark chocolate, right?
Yeah, before you add in the sugar.
And can't you have a little sugar, like 72%?
Yeah, if you eat like that, a little bit of that dark chocolate. Yeah.
Christmas is coming.
Exactly.
And winter is coming.
You say in the name of the drug, other than,
The drug that is like not very well recognized, low dose naltrexone, and I'll write the word naltrexone up here. So this is a fascinating drug because naltrexone is actually an anti-opioid. Yes, it actually blocks the opioid receptors. But when you use it in a very, very small dose, it actually blocks them and then puts them back to baseline. And it actually has beneficial effects in terms of helping us to balance back our own internal opioids. And it also is anti-inflammatory on the nervous system. Yeah, so low dose.
And it's over the counter?
No, this is not a good. No, and that's what I was saying. I didn't focus on medications because since you guys can't prescribe medications, but then when he asked that question, I thought I would throw that out there.
So what's low dose?
So the regular, so this has to be obtained from a compounding pharmacy and it has to be written, you have to get a prescription from a physician. So the normal dose is 50 milligrams, and that is used for a different purpose. So low dose is starting out usually like at 3, and yeah, so really, really, really low dose. Yes, and we're out of time, right?
This was about a question, because I watched Blue Bloods.
Oh!
And so when they have an opioid overdose and they give them a medication.
It's Narcan.
Oh, okay.
But Narcan and naltrexone are, they're
related?
different, yeah, they are different.
Cousins.
Exactly. They're different opioids. They're more like brothers than cousins. Close, because something like buprenorphine, which I can never say that word quite right, but that is more like a cousin.
Oh.
Because that has a pro-drug and an anti-drug. So, and when they're using it though in that situation, then they're using a much bigger dose because they're actually trying to reverse the opioids and make the person start breathing again. Yes?
There are no compounding pharmacies in the area, though, are there?
Yes, there is and there isn't. Young's Pharmacy up in Merrill will compound it and send it down here, and you can pick it up at any of their stores. You don't have to drive up there.
Huh.
There's no extra charge. In fact, so many people are now prescribing low-dose naltrexone in this area that they're starting to carry it at the Young's on Bridge Street. I just talked to the pharmacist the other day, and I told him, this is a drug that I am planning on using. Can you carry it in the pharmacy so a person can just like go from my clinic and then go pick it up and not, like they would any other drug and not have to wait for it to be compounded? And they said yes, that they would do that. Yes?
can you move from an opioid like Norco into the low dose?
That's a good question. So you wouldn't be taking both at the same time. So this would be instead of that, and you probably want to go off of that and have like a little bit of a washout period. And likewise, if you're going to have surgery, then you'd probably stop taking it. I mean, there's nothing bad's going to happen. If you're taking this on a regular basis and you get in a car accident and you break your femur and you have to have your femur rotted, nothing bad's going to happen. They're just going to need to give you more pain medicine than they would have otherwise. And it's going to show up on your medication list, so they'll know that you're on it. So, but you definitely would not be taking both. Yeah, you would need to go off of that first. So, and I think we're pretty much done. So.
I mean, we could talk to her all day, couldn't we? Very nice job.